wanting to do?
Are we live?
Yeah, we're live.
All right. I'm Dr. Shiloh. We're doing a complex ablation actually today. This gentleman had a EVLT or RF ablation actually, I'm sorry, done a while back, and he still has recurrent symptoms, or has recurrent symptoms in his leg. And we've discovered essentially an accessory GSV or large tributary that refluxes, and then also his anterior accessory saphenous vein that refluxes. So today we're going to try to treat both. So this isn't your traditional procedure, maybe a bit more complex. We require a few tricks of the trade here. Hopefully people can learn something from it. So first step is just getting access to this tributary. It's here on the medial thigh, little pinch. Traditionally, if this was a GSV ablation, we'd be going down a little bit lower, but it's not. So you can actually, I'm staring at my ultrasound monitor here, and we should, boop, just got access, I could feel it. Interestingly enough, actually, it didn't, the wire appears to have stopped. Let's see if we can get our sheath in. So we have wire access, and we're going to try to get our sheath in place here. Just made a little small nick in the skin. I'm probably going to need the wire. A little pressure. Normally this wouldn't be so challenging, but you can see I change sometimes to make sure. Alright, well, we definitely have some access, so now we definitely have access, as you can see. So what we're going to try to do now is use the wire, which is a nice interventional radiology trick here, to this, interestingly enough, seemed like a straight shot earlier when I first scanned him, much less now. So this is an 025 hydrophilic glide wire made by Cook, known as the Roadrunner. A little more blood. So. I need the torque device for this. See, the wire's getting caught right there. Where's the torque device? Okay.
Me? Yeah. Sorry. I'm trying to. Thank you.
Not my favorite torque device, but I have my own favorite, but this isn't it. This comes with this thing. So. wire to go. You can actually see the wire on the ultrasound monitor. So now that we have the wire, we can introduce the ablation device. Take that off, please. Yeah. We only have the 100 cms now? Okay.
Let me see if I have.
Do we have a 60, you think? Just be careful. This would not have been possible without that wire. So what happens is that wire allows me to navigate turns, and because the device is like a pencil, it's pretty rigid.
Right.
So you can't, the pencil is not going to turn very well.
Right.
So it will follow the wire. I'm hoping, this is a relatively floppy wire. When I work at the hospital, we have an innumerable number of wires.
Right.
All types of stiffness, all kinds of characteristics. All right, it's fine. But unfortunately, I don't have all the different types of wires. This is usually fine.
So this
Right, we're gonna have to wet this wire down.
Sure.
Here we use the Venefit closure fast system. We're going to then go plug it into our brand new box over there in the corner. Make sure the device is functional.
And I'll give you this.
Any comments or questions?
I have not seen any. Hello from Russia.
Huh?
Someone said hello from the Russia. That's about it.
Nice. How many viewers you got there?
14. It's up to 20.
It was up to 20.
So I'll do it. You hold it.
Yeah. Well, but if I was like some Howard Stern actor, I'd have 1,000 viewers.
Yeah, right. Beetlejuice.
Yeah, Beetlejuice.
Beetlejuice is
Yeah,
the...
I guess.
That's why I actually heard about this on Howard Stern, believe it or not. I was listening to it, and he said, "Did you hear about this thing, Periscope?" And that all the various whack packers, all the weird characters,
Right.
have their own show now, because it's basically like having a free show,
Right.
right?
So someone was wondering what this procedure is for.
This procedure is for varicose vein, symptomatic varicose vein. So, unfortunately, he has a bad valve or bad valves in the superficial venous system of his leg, and they're never going to get better on their own. So we are going to ablate or burn this vein instead of physically removing it from his body, which would be very traumatic and painful. This is much simpler. Just want to make sure my wire still is in place. You need a tripod?
You need
Is that what you're saying? Your hand's shaking?
No, I'm switching every few minutes.
Oh, you mean because it's getting tiresome
You got it?
to hold?
Mm-hmm.
Well, we have a tripod for our camera.
Do I have to straighten this a little?
Well, no, it's just that, the problem with this, as you know, when you have a hydrophilic wire, it dries out. Once it dries out, it's hard to get it to move. How long of a wire? I'm sorry, how long of a wire did you give me, Tracy? Is it
180.
180? All right, we should be fine then.
Someone said you guys need a tripod for sure. I don't think I'm shaking that much.
Listen, you get what you pay for, I guess, in this business. And since Brad here isn't getting paid anything for this today,
He's allowed to shake.
he's allowed to shake a little bit. This is our first go around here at periscoping a medical procedure. Not sure how many of these have actually been done already. Probably not many. This part is tedious and would normally not have to happen, but unfortunately he had this treatment done elsewhere previously. And I better not have just given up access. No. And so I had no control over that part.
Still going there.
It's just what happens is,
Should
because it's such a long wire, you could try.
Someone just asked if the patient agreed
Agreed to what?
to
To the-
periscoping the procedure.
Yes, of course. I would never have done it otherwise. Patient's wide awake. This procedure doesn't require anesthesia really. We will be numbing it at some point here in a few minutes. But that's the beauty of this procedure, is that it can be done in my office. All right, you have the wire? Gotta get the wire
Yes,
back
sir,
there.
I got it.
Okay. Now let's hope that the wire. See, Anisha, you have to, you can't just hold onto the back. You have to hold.
Tight.
You have to get back action. No, it's not going to work now. This whole thing is now jammed up. It's not going to come out. It's not just holding on to everything. As I'm advancing this, it's supposed to be sliding over the wire, okay? Not just holding it, and now, oh, there we go.
It's just, I'll keep it tension there.
Otherwise,
I have a little tension there.
see, the problem is it's the, where are we here? Okay, so we should be, straighten your leg out here, Tom. It's hard to see.
Watch out.
No, the issue is that it's tough to see now. There's the sheath. The catheter. Is here somewhere. Oh, there it is.
It's almost there.
Yeah. Oh, the catheter was actually all the way down there. Just where I wanted to be. There it is. There's the tip. You take a picture of that?
Good.
Yeah.
Sorry.
See, there's the tip of it. That's perfect, actually. Okay, great. I just thought it was going to be a little further in. Okay, now we're going to take the wire out.
It's up.
Okay.
Close it.
Okay. Now, next step.
More seam.
So the next step in this procedure, I know that took a little while, it normally wouldn't have, but is that we're going to do what's called tumescent lidocaine. And tumescent lidocaine is a solution invented by a doctor named Klein. It's actually also known as the Klein solution. And it's a mixture of saline, lidocaine with epinephrine, and bicarbonate. So you can do a lot of things using tumescent lidocaine. So what we're going to do now is we're going to surround this vein with lidocaine, and once we've done that, it will have numbed the vein as well as surrounded the vein with the solution. This is sort of an awkward spot, but so we're using a pump over there called a Klein pump. And what it does is it just pumps out saline, which I'm going to then use to surround this vein. How you doing, Tom? So what you can't see, I guess, because Brad is only showing me, is the ultrasound. And you see that time the needle's right on top of that vein. It's perfect.
Right.
So as I step on the pedal, you see how it telescopes around that?
Yeah.
That's really what we refer to as very good tumescence, because now it's literally just surrounding that vein. You see, and in the middle of that black is that line,
Right.
is the device. See, as I add more saline, it sort of dissects around the vein for me, which is what we want to do. Now my assistant here, Aisha, is going to turn your knee out a little bit towards me. Sure, perfect. Is going to now spray with some freezing spray. We use ethyl chloride. Go ahead.
Sure.
And then we're going to continue on. That's good. Little pinch. And then see the needle's right where it should be. And then we're going to numb this up some more. Now the last doctor did this, he did this in the OR with you completely asleep. Right?
Asleep.
Do you see how it's not necessary? Really?
I do.
The real reason, and one of the benefits of not having people asleep is that there are nerves that are around here too, and that you could burn them without, if you were dead asleep, we'd have no idea that we were burning a nerve. But if inadvertently that were to occur here, you would say, whoa, I feel something, and then we would stop the procedure immediately. So it's really a nice way of reducing complications, and certainly putting people under general anesthesia for a procedure that can be done under local makes no sense from a safety standpoint, because you can always have problems, you know. You knock your teeth out, it takes you a while to wake up, you aspirate, all kinds of different things can happen. See the needle there?
I do.
That's pretty cool, right?
It is.
So we're just, as you can see, it's just sort of telescoping around that. And we're just going to keep going up your leg until we get to the spot where we want to finish. Okay. And I think, are you feeling these jabs or not much?
Just very mildly.
Yeah, we find that the freezing spray does help. I mean, it can't completely make them go away, but oh, look at that. See that?
Yeah.
That was pretty cool. Just went right up. See? We're working our way up his leg here, all right, Aisha? Once we've covered this whole area with the tumescent lidocaine, then we will begin our actual ablation. And there we can actually see what appears to be the tip of the catheter. You see that there?
I do.
Can you take a picture of that, Tracy? All right, one more I want to do here. You can also see that the temperature has dropped nicely. See, the temperature initially started out as close to your body temperature, about 36 degrees Fahrenheit, or I'm sorry, Celsius. And then as we do this, it dropped now to 25 because we're the device has a temperature probe on it, and it can sense that the temperature is much lower there now because it's surrounded by this lidocaine. So, all right, well, we have reached a good amount of tumescence. We have a nice temperature in there, so now we're going to start our ablation. So basically, we just turn the device on, and we're going to apply some gentle pressure. The device is going to heat up. Right now, it's heating up to 120 degrees Celsius. And I'm pretty sure Tom over here is not feeling anything, which is, you know, means we've done a nice job of getting good tumescence. We burn each segment twice, which is just our standard. The IFU says you have to do it just once, but most people do 2 times per segment. Any questions, comments over there, Brad?
No?
In Periscope or
Our viewers have gone down a little bit.
maybe it's because you're filming.
Nah, I think I'm doing pretty well.
Well, it's not me then.
Listen, people come in, they watch for 5 minutes. They don't have all day.
Right, they don't have all day? Why, how many viewers do we have now? Wow. 4 of those were probably in your family, Brad.
One of them's probably CJ.
Listen, this is just a test run, okay? At the very end of it, you'll be able to see how long people viewed and what their retainership was. In other words, like, did people stay on? Did people just pop on and off?
Looks like out of these 5 viewers, only one of them is on a phone. 4 of them are on the web.
I don't know how you view it on the web. I guess there must be a web-based version of it.
This kills the battery of your phone, by the way.
Oh, does it?
Yeah.
Well, maybe we won't tape the rest of this procedure then, since we've gotten some of it done.
Oh.
Why, how low is the battery now?
24.
Really?
Just like the charge.
Well, we will on it after this case.
Somebody just
Huh?
somebody else just
Any hearts? Anything?
Oh yeah, you were getting
Oh,
a bunch of
yeah,
hearts
some
before. Probably all from CJ.
Look, they're sending
Yeah,
hearts
now they're
now.
sending hearts.
All from CJ. That's good stuff. CJ. This is it for this part.
Okay.
Why'd you tell him I was on?
Yeah.
Did he get on it, you think?
I'm not sure.
He's busy somewhere.
Get more hearts.
Just mentioning CJ gets his hearts.
Nah, no hearts there.
Not too bad, huh?
Not at all.
This is going to take care of a lot of these varicosities. This, I'm hoping, will take care of some of these other ones up here when we go into the anterior accessory saphenous vein. All right, we finished with this part. Let's see, we'll take the catheter out. Here's the device. Looks the same as it did before.
Mm-hmm. We do now. Mm-hmm.
Your leg will probably feel a little numb over here.
It does.
I'm glad that ulcer healed. That was.
Oh yeah, me too.
It's not often that we do like sort of work from the bottom up,
Right.
backwards. But in your case, I knew that needed to happen. Normally we work from this side down because you want to take the pressure head off of that problem there, and that may solve that problem. But since you could clearly see there was an issue there.
Yeah.
Someone said I wish I could do this on myself, but luckily Dr. Shiloh can do that.
You wouldn't want to do this on yourself. I'm all for trying stuff, but it would not be a good thing to do. It's not that easy. If you have varicose vein disease, wherever you're from, I'm sure you can find a qualified either interventional radiologist or vascular surgeon or whomever who's qualified at doing these procedures. This particular procedure was rather complex, and not for the faint of heart. In other words, the easy ones and anyone can do these. That one, as much as it may not have looked, it was rather challenging, especially getting that wire to go.
Someone just said they're taking a flight. Yeah, taking a flight here.
Huh? Taking a flight to IR.
No,
No.
taking a flight to Pennsylvania, but the person's in IR.
They are in IR?
Yeah, that's what
Oh,
they
is it-
said.
I know who it is.
Self-proclaimed.
I know who it is, probably. Is it Noreen?
Hearts, you're getting hearts.
Hearts are getting hearts.
Yes.
Yes.
Yes. We're going to have to meet up sometime, I guess, at a meeting. Wow, this AASV really decompressed a bit since the last time I looked at it. But I think we could still access it. All right.
Okay,
I need the lidocaine for the AASV here.
She said definitely.
All right. Well, hopefully I'll be at the SIR meeting in Vancouver. We'll see. Although that's a long time away. All right, little pinch.
Getting this ready for you.
I know there has to be a component of like an emotional like spasm or something, because these veins are always smaller as we're doing these procedures than right when we're scanning.
Would you like another wire or this is okay?
I guess if we have another mandrel, do you have another mandrel? This is essentially, this part of the procedure is like doing a PICC line, where we simply just gaining access to a small vein. If you could see how small this vein was that I was accessing here.
OMG, that's so true. The veins shrink during procedure.
Andrew?
Yeah, I'll take the mandrel. Yeah, that vein was this AASV that I'm using to access the origin of the GSV, which was previously ablated, is not very large. So we'll see if we can get this wire to go here. Success. For our next periscope, we'll have a dueling cameras maybe. Ah, see, look, there's the wire. You probably just show the screen over there, Brad, so they can see the wire in the middle of the screen. Their wire is right there in the middle of the screen. That's the 018 mandrel wire. Now we're going to introduce the sheath. All right. What's the battery life at now, Brad?
23.
No.
Oh, it hasn't gone down that much. I think we started around 40 though.
Nah, it's just my phone stinks. For whatever reason, it's always working. It's never on standby. So the standby time and the phone time are the same. Can I get the blade?
Get a new phone.
Yeah, I do need a new phone.
Just got that.
No, it's not that. It's just AT&T and, you know, the hospital, lead-lined walls, all that great stuff.
You're supposed to feel like a heckler.
This is crazy. I don't even know if an IR procedure has been done on Periscope yet. I mean, I may not be like Stan Cope or one of the originators of IR, but I'm the first one to Periscope a procedure, I think. We'll find out later. I'm sure someone will one-up me. Somebody from Miami Vascular flying in a helicopter to do a procedure. They used to do that. They used to, if you go to the meeting, in Miami called ISET. 1 second you see Barry Katzen, who's like a big name in IR, and the next second he's in his lab doing a live procedure, and you're like, how did he get there? And they used to helicopter him from the meeting place, from the Fontainebleau or wherever, to it's also a bit tenuous here. That went nicely. Now we gotta check our positioning. There's the catheter. You see it, Trace?
Mm-hmm.
You should. I just gotta. I'm sorry, Tom.
It's okay.
I gotta get a little bit closer to your point. Oh, look. The catheter is. This is where we have to make a major decision here. So the catheter is right there. See it? There's the ASV. Now he's got this GSV origin, which, oh wait, where did it go, the catheter? Oh, there it is. Oh, see? Whew. I gotta pull this thing back. Whoa, where's that vein up there? Sorry, Tom, I know.
It's okay.
It was all clean now.
Wow, look at that big dilated tortuous veins up here.
Mm-hmm.
I just think I need the lights down a little bit. Yeah, well,
Yeah, there's no little bit.
yeah, unfortunately, we don't have a dimmer here. You could see the ultrasound. So, the catheter, I'm pulling the catheter back.
In your way.
Now, in a normal GSV ablation, we would want to keep the catheter 2 centimeters away from the junction with the common femoral vein in order to avoid getting a DVT. Now, in his case, I'd like to do the same. I'm just trying to get the right view. You see, there it is. You see it? Tracy, did you see it come in there? There it is. Now, the question is, can I get that? All right, take that. Now we're going to measure this. Perfect. Okay. But it's a little bit trickier than most because of the previous surgery. We would have been done already. You've been outside having a hanging out with your wife. Instead, I'm still messing around with this, trying to make sure it's. I almost always measure twice just because, like in this case now. You felt that?
No.
It's very hard to get the right view on it. That's why, right? Is it that I'm pressing on your groin?
I could feel it hitting up on the, didn't hurt, but I could feel it, I guess, hitting up onto whatever's up there.
Yeah, see, the thing is I want to try, remember I was using this ASV to get in here, and what happens is that, for whatever reason, it's like, see, it's there, there's the tip, and now it's too close, you see, now it's right to that terminal valve, so I pull it back. There it is there. It is back to the two messing. How's our viewership now? That was pretty boring.
Yeah, it's down to 3.
Yeah. Sorry.
It'll go back up, don't worry.
That was boring. I don't blame anybody for not watching a dark screen, but it had to be done. We're back to two messing here. All right, ready with the freezing spray? Good. If you show the screen right now, you can see there's the needle touching the catheter, and that's a perfect position from which to do the two messing. You can see how it sort of travels along the vein. Now, one of the little challenges here with him is that he's got a lot of superficial varicosities here. Go ahead. I'm going to try to avoid as I do the rest of the two messing.
Your IR friend's been constantly in and out.
Yeah, well, I'm sure she's doing cases or doing something. I wouldn't blame her to go constantly in and out of this case, because I'm sure she has a gist as to what's going on. Okay. Sorry about that one.
That's okay.
There's certain areas that are a little bit more sensitive than others, as you can imagine. I've actually found that that like sharp going through is better than trying to go real dinky in there. You know, it's just for this especially, like once you get through the skin, the rest of it's kind of been numbed a bit by all the other numbing I've been doing, so. Probably don't feel the deeper stuff as much. It's right, just the skin area. See that one? I must have hit a vein. See? I feel like that was going to potentially happen. Is the camera putting 10 pounds on me, or?
I mean, it's kind of hard to tell with the.
You know, you're supposed to say no.
You had viewers up to 14 at one point, I think.
Yeah, viewers up to 14.
I saw 21 at one point.
The right answer was no, Brad, okay? I don't need an excuse. Just say no. No, not you.
I mean, I could be honest, or...
No, I don't want you to be honest.
Not till we're honest.
Not till we're done. That's right. Tom's right. Can you get me some more?
Yes, sir.
Why are you laughing so much, Brad? I can see you.
Just
over
get
there.
some hearts.
Is that it?
Yeah, it's the hearts.
I don't think that's it, Brad. And I'm gonna be able to watch this replay too.
She said more hearts.
I'm gonna watch this replay, Brad. That's it. You're not getting honors for this fake rotation you're on. Where are you, needle? We're watching the temperatures dropping again, so we know that we're getting close. I think. Yeah, well, let's try one more time. I got one more. Little pinch. Little big pinch. You really want to make sure that the junction is tumesced really well.
I'll take that.
Okay. Maybe my watch telling me it's time to stand up. I'm just pushing a bit here. Sorry, buddy.
That's right.
All right. Can you turn the device on, please? This won't take very long because we only have this short segment to ablate. So we're ablating the ASV, and I use the ASV as an access point to get to the origin of the GSV, and again, and hopefully treat the GSV, the residual GSV, at the same time as we're treating the ASV and all these collaterals. So between this and this, it's rather complicated. Either one of these are both individually or complex, but sometimes it's what you have to deal with. You all right?
Fine.
Feel anything?
No, nothing.
So because it was only that one segment, what we're going to do now is just pull the sheath back, because the 7 centimeter mark is right here at the sheath. You can pull the sheath back and then just pull it back until we see the 3 centimeter mark, which is right there, and then ablate again. And that's it. 2 more ablations and we're done.
Nice.
Yeah, that we'll have to save for another day. I mean, probably just need to foam that. It's just too short of a segment to treat, see? I mean, even if you accessed it with a 3cm probe, you wouldn't have any room to ablate this, so this is probably better to be treated with foam. But we just have to follow the logical progression here. He had actually started with a venous stasis ulcer of his foot that we treated with foam sclerotherapy of perforators by his foot, and that healed up very nicely. The peanut gallery. All right, take this out. Then we massage out what's left of the blood in the compartment.
Doc, do you wear compression stockings at work?
Yes, he does.
Sometimes, when I remember. All right. We're taking our post images here. We show that the common femoral vein is still open. Go ahead. As is the origin of the GSV. But then we get into our ablation zone there. Nice. Take that. And there's all these prominent varicosities, but we're going to hope that they're going to decompress. And then I'm going to look down here. Yep. We're done. That's it.
Nice.
And we're going to just wrap this up and we'll be finished. Thanks to Tom. You can stop filming.
All right.